Radiologists, we are used to endoscopic biopsies. So here you're going across the duodenal or gastric wall or rectal wall. So we're basically going out of the lumen. So you're always scared, but the Doppler helps us to achieve this. And this is what we really want to do it. And for that, there's nobody better than Professor Wan Seo to tell us about it. So. Professor Seo is not only chairman of the Department of Internal Medicine, University of Ulsan Medical College and Asan Medical Center. It is the largest teaching hospital in South Korea. Advanced endoscopic work in the range of endoscopy, including its classification of colonoscopy, reading, EUS-guided treatment of pancreatic cystic tumors, and EUS-guided ablation therapy for pancreatic solid tumor, for which he is a world leader, and will listen from him about it in coming meeting. He also served as the Secretary General of the Endoscopy Organization, as the Chairman of Steering Committee of Endoscopy. He started this, what Dr. Deep alluded to, the International School of EUS, which is called as WISE, and it helps the beginners and trainees, and it has a nice teaching module in which they have didactic lectures and some training. So, Professor Wan Seo, welcome.
Thank you, Yogeshi. It's my real pleasure to join this meeting. Before starting, on the email, it told me that this is 45 minutes talk. So I asked Yogeshi again one more time, is it really 45 minutes? I just used to deliver this 20 minutes talk. He confirmed that it is 45 minutes. So I inserted more and more slides. So the total slide number is more than 100. But I will keep it short. Because 45 minutes is quite a long time, so I want to spend a little bit of time for history and technique and the impacts of FNB. And also I want to share my experience, my own tip to maximize EUS-FNA yield. First, history of EUS-FNA. EUS was introduced in early 80s. These are the doctors who actually opened this new field. And then Olympus was one of the leaders on this field. And the EUS-guided FNA was started early 90s. Peter Billman, Denmark, he was one of the pioneers. And Mark Giovannini, these are the guys who first opened the door of tissue acquisition under EUS guidance. EUS can delineate the lesions not just inside the gut wall or in the wall, but outside of the GI lumen. We can delineate the lesion, and on the EUS view, we can directly puncture the lesion and get some tissues or cells. So this is called EUS-guided FNA. If you look at this data, in 1993, Peter Billman mentioned that it is possible to do EUS-FNA for upper GI tract malignant lesions. And also Ken Chang reported FNA of pancreatic cancer in 1994, about 30 years ago. Yeah. This was the history. Some of you may remember this needle. This is Olympus power shot needle. This is spring-loaded, because FNA, we need to push the very strong gut wall. So we need, exert quite strong force. And for that, initially we made this kind of power shot needle. And after location of the lesion, if we push the button, then it fires and go into the lesion. But later, different types of FNA needle came to the market. So we have variety of needles nowadays. But olden days, there are not much different types of needle, FNA needle and FNB needle. Nowadays, we can use a lot of things. But basically, the structure of FNA needle or FNB needle is quite similar. It has needle handle and also stylet inside. And there is, most of the times we are using safety link to prevent overshooting of the needle. Sometimes behind the lesion, there is some critical vascular structures. So we need to avoid that. And for that, we can use this safety link. And also slide sheath adjuster. Before doing puncture, we need to locate the needle sheath in an ideal position, then expose the needle. This is two-step. And this is a negative syringe to apply negative pressure. This is the same needle sheath and the needle, and also inside the needle there is stylet. After puncture, we remove the stylet and apply negative pressure. Or yeah, I will explain it later. This is at the beginning period of EUS-FNA, especially the Denmark Peter Billman group was very much interested in mediastinal anatomy. And this is a CT image. And under EUS guidance, we can do FNA of these lymph nodes. This is a lung cancer lymph node staging system. And we are insisting that even though there is EUS system, we can do FNA of lymph node station 1, 2, 3, 4, probably 5 if it is enlarged, and the 7, 8, 9. 7 is subcarinal, and 8 and 9 are actually upper lower part esophageal area. So we are targeting from esophagus to these areas, 2, 4, and 7, 8, 9. But these areas, these peribronchial areas, are the main area of EUS targeted area, these areas. So this actually made remarkable progress in terms of lung cancer staging. Without, before this, they need to do mediastinal biopsy for the accurate staging of lung cancer. It was quite invasive, but this made a lot of progress. We can do non-invasive staging of lung cancer. It contributed a lot for in our medicine. So during the time, this is my slide. This is lung cancer, but when it is extended into the mediastinum, even the lung cancer we can do biopsy of the lung cancer. Through this window, we can puncture this lung mass and get some adenocarcinoma tissue there. And this is very small lesion, 6.7 cm, 6 millimeter. During the period, the CT cannot pick up this size lymph node. At least more than 1 cm lesion can be picked up by CT. But under EUS, we can get histology, not just depicting this lesion, we can get tissue from here. So we can do diagnose. It was quite a surprising impact. I mean, it made an impact on our lung cancer staging system. And not only for that, if pancreas, yes, is the main target of our EUS-guided approach, but we can also do FNA, FNB of some retroperitoneal lesions. This is left adrenal mass, left adrenal adenoma. When you look at, previously we tried to do percutaneous biopsy on the radiologist, they approached posteriorly, but when you think the distance from skin to this area is quite long distance and quite invasive, they do paravertebral approach. But on the EUS, we can delineate the left adrenal mass just outside of the stomach wall. This is just a 1-2 cm distance. So we can do biopsy here, and we can show the adenomous tissue or adenocarcinoma tissue from left adrenal gland. It was also quite surprising event. So that was beginning period of EUS-FNA. And then after that, with the introduction of a lot of accessories and the different types of needles, we made progress in terms of the techniques of EUS-FNA. But before starting EUS-FNA, basic requirements are already Binay and Rongsun explained it. We should know the principles of ultrasound, and also training for linear EUS is absolutely necessary. We need to be a bit competent on the anatomy and lesion localization and identification, and the positioning of the lesion in an ideal position. These are basic steps before going to EUS-FNA. Let me move on the puncture and the tissue acquisition area. When we do EUS-FNA, we need to find the lesion, and not just find the lesion, we need to locate our echo endoscope tip in an optimal position. This is not an optimal position. To see this is, if this is the target lesion, then we need to insert scope around this area. Please click, can you click how I can do it? This one? Not this one, no. Not this one. Click it and play the video. Please. Yes. Not working? This is graphics. Just a moment, I can do that. In this mode. What about this one? No? As you see here, if you insert the scope, then we can locate the tip of echo endoscope to visualize the target lesion. But then the lesion is located around 5 to 6 o'clock. Yeah, you can do that. 6 o'clock here. But if you push further, this is, I think, the ideal location for targeting. But sometimes the lesion can be located on this 9 o'clock or this area, 3 o'clock or 4 o'clock position. Push one more. Yeah, and one more. This is the angle we can make during FNA. We can use a little bit of elevator movement. Too much movement is not good, because if you elevate, if you do elevation a little more, then there is strong resistance and the needle will be bent after just one pass. So not recommended too much, but we can do a little bit of adjustment. And one more. The lesion should not be located on this area when you are targeting the lesion. And also, one more. Yeah, this is not the ideal position. Should be located around this area. Next slide. Okay. So this is phantom. This is gel, and this is a grape. And we are assuming this is the target lesion. And push the button. When you do FNA, play the video. Yeah, the lesion should, this is not the ideal location, better to have on this side. So for that, if you pull the scope backward, then this lesion will go the opposite side. If we push the echo endoscope deeper, then the target lesion will go to the right side of the screen. So we need to understand this basic maneuver. And also we can make some up-down angle. If we make an up angle, then the target lesion, this lesion will go upward like this. When the lesion located in the deep position, we need to use up-down move. When the lesion is located like this area, then we need to pull our scope back. Or when the lesion is located on this, on the screen, then we need to push our scope inside. Okay, next. Next slide. Play the video. This is a big field up-down movement. The lesion moves like this. This is gel, so does not compress much. But inside the human body, this area is a little bit compressible. So deeper portion lesion can come up like this. But this is hard tissue, so we cannot get very close distance. But inside human body, if you do, this is up-down movement, and we can adjust the deeper portion lesion into the superficial part. So basically, push in, pull back, and up and down, those movements can localize meticulously the target lesion on an ideal puncture angle. Next. Best position maybe is 5 to 7 o'clock position below EUS-Prof. 5, 6 o'clock position, sometimes located deeply like this. This is not very good. Better to have superficially. And if it is possible, straight echo endoscope angle is better because echo angle, although it is visible, sorry, it is echoscope is like this, then the needle puncture is difficult. Better to have a straight line than and avoid a large vessel and minimize the distance between the lesion and the probe. If the lesion is located deeper here, then puncture, accurate puncture, and also panning movement is difficult. I will explain later. Play the video. And the second step is insert the needle and first adjust the needle sheath. Generally, needle sheath comes on this direction. As you can see here, this is needle sheath. Needle sheath can be located like this or like this, but I recommend locate the needle sheath just above this plane. Yeah. Because if you start from this position, then we can make like this angle. But if needle sheath is on here, then we can make just a small angle. Small window, we can do puncture only through narrow window. So I generally recommend needle sheath position on this top area. And insert the needle like this and puncture the lesion. And then if the needle is in the target, and then try to do to and fro movement. Before this, we need to remove the stylet and apply negative pressure. And then you can do to and fro motion like this. If possible, you can do fanning movement into several different directions. But the distance from here to here is quite long, so it is difficult to make fanning inside the lesion because the fixed portion is too long. Next. Next slide. Oh, sorry. Yeah, play the video. You can adjust the elevator like this. But with this position, there is strong resistance. As I mentioned before, after one pass, the needle will be bent. And if the needle is bent, then you can use it, but localization of a needle tip in a EUS plane becomes difficult because it's frequently off the plane, goes off the plane. So you cannot know whether the tip is located inside the lesion or went outside of the lesion. And okay, play the video. When you puncture the lesion, we need to adjust up, down, and right, left angle, and try to locate. From this position, we lost the needle tip plane. So we can adjust the right and left angle and the up, down angle a little bit and talking, and we need to relocate the needle tip clearly on EUS view. This is important when we do to and fro motion inside the lesion. We recommend to do to and fro motion inside the lesion. If you come outside of the lesion, then you can pick up normal pancreatic tissue or other tissues. So we recommend to do to and fro inside the lesion. And this is fanning movement. I am starting lymph node biopsy from this area and then slowly extending and try to cover the superficial upper part of the lesion. This is called fanning movement. It can reach several different areas. We even talked that there is some difficult levels on EUS-FNA. The mediastinal tumor, mediastinal lymph node is quite easy target. It started early, almost 30 years ago. It is because when you do EUS mediastinal lymph node biopsy, the echo endoscope position is quite straight. It is not curved or not bent. When you target the pancreas head, EUS scope is like this, located like this. So through this angle, it's difficult to insert the needle. But mediastinal lymph node is straight, so this is relatively easy. And if the lesion is very large, liver, adrenal, perigastric node, and nowadays pancreatic area is the main target of EUS-FNA. And head is still a little bit difficult, especially the lesion is located in uncinate portion. And the gastric wall biopsy, if the lesion is small, there is a little bit of difficulty. Let me move on the factors affecting FNA yield. The first is anatomical location. If the lesion is located in a difficult area, accurate targeting can be difficult and it will affect the yield. And the angulation of the tip is another factor. And whether we do fanning or non-fanning, it will also affect. If you do fanning, then the chance of getting good quality sample is high. And the tissue stiffness, consistency may affect the result. This is an old study, the Cheyenne group. This group is very much interested in randomized study. And they did fanning and the standard FNA, and their conclusion is when you compare single phase diagnosis rate, without fanning just 58%, with fanning 86%. There is a significant difference. So if it is possible, better to do fanning. And also, needle size can affect that. This was initial period when we are just doing FNA. So we are very much focused on what size of the needle was the best, 22, 25, or 19 gauge, while with suction or without suction, with stylet or without stylet, while presence of on-site cytopathologist. These things, we are very much obsessed on these things. 25 gauge needle has advantage. We can target very hard lesions. The puncture of hard lesion is very easy, and also small lesion targeting, it is good. And we recommended not to pass through the tumor when you are targeting lymph node. This angle is better because the risk of false positive results if you go through this angle. And as I mentioned, we were very much obsessed on which size of needle is best. And there was some meta-analysis saying that 19 gauge needle has limited data, 25 gauge needle appears to be advantageous to 22 gauge needle, but later it changed. During this period, the meta-analysis insisted the 25 gauge needle is a little better. But this study is 22, again, comparing 22 and the 25 gauge needles. So for solid mass, 22, sensitivity 85 and specificity 100%, but 25, 93%, and 25 is more sensitive than diagnosing pancreatic malignancy. So during that time, most of the article mentioned the 25 gauge needle because it can go through the angled area and hard lesions. So for some period of time, many people recommended 25 gauge needle, but not now. Suction or without suction, it did not affect much, but with the suction, because of excessive blood aspiration, many cytopathologists did not like this, and they did not, recommend to do strenuous suction. 3FNA without suction was this article's recommendation. Michael Wallace, he published this article. And also with or without stylet, there was the randomized prospective study was conducted, but no difference. With stylet, without stylet, did not affect much. This was, yeah. And another randomized control study was started, but it was terminated early because of there is no significant difference in terms of diagnostic yield, proportion of inadequate specimen cellularity, and amount of blood. So this is trivial thing. This is the slide when I do FNA, I am on the slide glass, we smear it, we made smear. But during this period, we have problems. So sometimes we did FNA, but pathologists say low cellularity and there is not much tumor cell there. We cannot make any conclusion. And it was quite tough to overcome those kind of situations. So we try to refine our techniques by doing conferences between cytopathologists, and also every slide I made a photo of that and try to analyze our data. During that time, actually, the Western endosonographers strongly recommended the presence of on-site cytopathology is essential. It can increase the diagnostic yield. You should not do 5 or 6 times of FNA. If there is on-site cytopathology, the number of passes will be decreased. They published this number of needle passes with on-site cytopathology. The red the graph shows, red bar clearly shows the 1, 2, 3 pass is good enough. Without it, we need to increase the needle pass. And the sensitivity with on-site cytopathology is higher than without, and overall accuracy, it was much higher than this. So after this result, we also asked to our cytopathologists to come to the EUS room and please show up during my procedure, but we are busy on surgical specimen, even on surgical frozen biopsy result, we are a lot of, people waiting for that, so we cannot serve for you. That was the response. I asked several times. So I need to refine my technique alone. We do not have the luxury of specialized Western centers. So we try to analyze our own data, macroscopic visual inspection technique. When I do smear, I try, this is blood, a lot of blood here, but we can see this non-bloody whitish tissue core. So I take the photos of this, and we also can see some bloody granular spot. This is granular area. Not core, but granular area. If you make a compression, it will be like this. So after making this, we made photo, and we tried to identify which area actually had the real tumor cell. And we had a conference with our pathologist, and we marked several different areas. And but this is the area when the tumor cell was reside. So even though macroscopic inspection is quite difficult to know which area really have the tumor cell, cannot get the idea. EUS-FNA still have the blood contamination, and sometimes presence of benign epithelial cell cannot make the definitive diagnosis. And the tumors with desmoplasia were well-differentiated tumors. It's difficult to make confirmative diagnosis just based on several different cells. And it destroys tissue architecture, and it cannot be used for GIST or lymphoma or autoimmune pancreatitis. So later, FNB technique came into the market. Originally, this was the first one. I don't know whether some of you may remember. Have you ever used this Procore biopsy needle during your practice? No. Oh, you? When was it?
Probably about 6 years ago.
6 years ago.
Yeah.
Still available.
Yeah, we use it for patient technology similar.
Uh-huh.
We use it for the single pass.
Yeah.
We're using application.
This is a Cook device, and it has, yeah. This was original the Procore biopsy. It has around 1.8 cm specimen tray. This is pretty long, and this is dilated. And over this specimen tray, there is cutting sheath here. And when it is mounted, then it comes out very long outside the back endoscope. So this specimen tray is almost 2 cm. But if there is tissue here, then if we fire the spring, then it will cut the specimen over this area. So this is retract the handle in a pre-loaded position, and after location of this needle stylet inside the lesion and fire it. Then we can get this amount of tissue. It is, by visual inspection, it is really a satisfactory amount of tissue, huge amount of tissue. Then we can diagnose definitely with this. But the problem is, it is 2 cm length. So the lesion is less than 2 cm, we cannot use it. And also it is steep. And also technically quite challenging to use this one. And some of endoscopy actually made a complication during this procedure. So actually this needle disappeared from the market. So nowadays we cannot use it. But this was the first technique we did, EUS-guided biopsy. Technically demanding, risk of complication, lesion size should be more than 2 cm. And because of the stiffness, the lesion should be located in a favorable angle. And only skillful endosonographers use this one. But I use this, I was quite satisfactory using this device. So when Cook was trying to, remove this needle to the market, I asked them, please bring all the remained Turco biopsy to our center. I will use it. I have no problem with it. So for some period of time, we used all these things. But later, they developed this type of Procore needle, much safer than Turco biopsy. And the specimen tray, a cutting area is just 2 millimeter compared to 2 cm. It is very short. And it has very sharp angle here. So they marketed this needle. This is, click the video. This is Ken Chang's video. After marketing this one, Ken Chang made the video technique of doing Procore biopsy. Because of they want to avoid blood contamination, they use the slow pull style technique. So while he is doing to and fro in the liver, this is liver lesion, the assistant is slowly pulling the stylet back, causing some of negative pressure inside the needle, and the tissue fragment can come inside the needle. With this one, we can get this kind of specimen, but still there is some bloody, while sometimes blood coagulum may look like this, but we can get much more tissue than FNA. So compared to Turco biopsy, I'm still satisfied with this amount of tissue, but this is actually, we can call this microcore, not a true tissue core, but we can get some amount of tissues here. After this, many groups conducted the study, single-phase diagnostic yield of core biopsy, 25 gauge needle, and they did a 1-pass cumulative sensitivity, 2-pass, 3-pass, 4-pass, and they mentioned that if we do 3 or 4-pass, then we can get quite satisfactory results. By visual inspection, we can think about core is present, but histologically, real core was just 1/3 of them. So by visual inspection, we may be confused with real tissue and the coagulum. And after that, many groups conducted a study comparing FNA and FNB. But our group also conducted a study. This is FNA sample. On this sample, we just can see mature lymphocyte only. But same lesion, we did FNB. And FNB, it shows granulomatous tissue. So we can diagnose TB granuloma by FNB. And this is FNA of lung lesion. The FNA result was non-small cell lung lesion, but what type? We did not know, but FNB showed squamous cell carcinoma. And this is a bloody background overlapped with blood, so we cannot identify individual cells clearly, but FNB showed non-caseating granuloma, so sarcoidosis was diagnosed in this case. This one, a bloody cell nest. This is the problem of FNA, but with FNB, we can see the lymphomatous tissue, the lymphomatous tissue here. And especially when it goes to autoimmune pancreatitis, FNB is not very useful. FNA is not very useful. With FNB, we can do immunohistochemical staining, and we can see a lot of typical AIP features. So we recommend nowadays FNB for the diagnosis of autoimmune pancreatitis. We have several different models, and some groups actually did comparative study of different designed FNA, FNB needle, but they say that compared to considering FNA needle, conventional FNA needle, FNB needle shows much better result. And this also shows amount of core tissue is much larger in FNB, and the blood score was without suction, the score is low. So they recommend not to do strong suction during FNB. That's why Ken Chen group showed the slow pull technique. This is Francine needle from Boston. This is Charcot needle. Different designed FNB needles are on the market, so we have luxury nowadays compared to 20 years ago, 30 years ago. And the rose part, if you use FNB, rose cannot, the rose may not be necessary. FNB without rose can supplant FNA with rose. And also evolution of endoscopic tissue acquisition from FNA to FNB seems to be inevitable. So nowadays, the tissue acquisition trend is changing from FNA to FNB. And this also data shows those kind of trend. Lastly, I'm going to show you my own way of doing FNB tissue acquisition. As I mentioned, nowadays I'm using FNB most of the times, not FNA. FNA is for cystic fluid aspiration or EUS-guided intervention. For that, for the introduction of guide wire, I use FNA needle. But other than that, most of the times FNB needles. There are different models. And for blood contamination part, some people say that the negative pressure should not be applied, but in my practice, I still use the negative pressure. Sometimes without negative pressure, I did not get much amount of tissue. So from that experience, I'm always using negative pressure, not strong, but just the 10 cc negative pressure. But I use this filter paper. I'm not smearing it on a slide glass. I'm using this filter paper like a regular endoscopic biopsy. When you do stomach biopsy or ampullary biopsy, we are using this one and put the sample on here and then put those sample on formalin. The advantage of using this is if there is blood, the blood is absorbed by the filter paper. This is paper, so we can observe it and expose some amount of tissue on the surface of the filter paper. So if you see this, blood is observed, but still the tissue is here. Blood is observed, tissue is here. This is significant amount of tissue. Again, we can see tissue, white tissue core on this area. So if the blood is many, I use 2 filter paper to observe all the blood, and it can expose microcore like this, all bloody, but we can see this, and also very much bloody sample, but here and here, there is tissue microcore. So if I see this, I am very happy. Macroscopic on-site evaluation made my technique very much, I find my technique with this, because we cannot use on-site cytopathologist. Nowadays, I think on-site cytopathologist is not necessary at all. We are not calling them again. And we analyzed our own data. The diagnosis was quite diverse, but after two or three passes, median pass number is just 2 or 3 passes, and the median number of macroscopic visible core was 1.33. Mean number of blood tissue granule, not the core, some whitish area was 1. With this, we can get diagnosis of more than 98%. I'm very happy with this diagnostic accuracy. I think we cannot increase more than this, even though with the cytopathologist presence. So this is what I am doing nowadays. Anatomical location, because you define your technique of delineation and anatomy, Binay actually explained very beautifully the technique. If you're good at it, even though the small lesions in uncinate portion, yes, it is difficult, but you can target it. It is possible to target it. And angulation, because 22 gauge FNB needle is quite flexible, so most of the angle we can overcome it. And the fanning movement is necessary, stiffness, consistency, but still I'm using just the 22 gauge needle. In my stack, there are a lot of 22 gauge needle, only a small number of 25, but I rarely use it. Needle size 22, suction without suction, 10 cc suction, standard. If the first pass shows too much blood, then I remove the suction. And with the stylet, without stylet, does not affect much. So at first pass, I use with the stylet, but from second pass, I do not insert the stylet. And the presence of on-site cytopathologist, not necessary at all. Number of pass, generally 2 or 3 pass. FNA, FNB, most of the times FNB. So this is my final conclusion slide. EUS-guided tissue acquisition evolved continuously over the 30-year period, refined needles and sample preparations, and with the changing trend of FNA to FNB, we can get a large amount of tissue with a less number of needle pass and higher yield. Definitely, we are moving from FNA to FNB, and without on-site cytopathologist, with macroscopic on-site evaluation. Thank you very much for your kind attention.
Excellent talk, Professor Seo. So, any pertinent questions amongst?
From the one who doesn't do FNB. So it seems that we're moving to FNB more than FNA. But in your opinion, for certain condition, let's say like neoplasm versus embryonic process, because you mentioned about the AIP, right, and maybe because the problem, think FNB is useful in those things. Any limitation? Is it something completely answered compared to core biopsy? I mean, FNB and core biopsy with some other means.
We started from FNA, and we still have that technology. I'm not saying that we have to abandon FNA yet, but FNB gives better yield and with less number of pass. So less amount of time and energy. So most of the times in my practice, I prefer to use FNB instead of FNA. But some doctors, it depends on the level of their experience and also availability of the facilities and accessories. If they are comfortable with using FNA, I think on that setting, it is wise to use FNA needle also. Why only FNB or FNA? If those two techniques are available, so select as you prefer, and if the technique, you can get better yield.
I think this is a very important question, what you raised also. So for all solid lesions, I think I would say that FNB is better. And if there is any cystic lesion, then FNA is a good technique, because as sir said that the yield is better and the passes are less. it's more safe. And I know some of the experts, they only take one pass. So I think it really gives you a really good chunk of tissue. I wanted to ask, what's your experience with the cytolite? Because some of the people, they put entire specimen into the cytolite instead of putting it into the formalin or something.
Our pathologist, actually, when we do FNA, we made, at the initial period, because of several times of failure, we made a lot of slides. At the beginning period, we just started 6 or 7 slides. But after several failures, we made about 20 slides, 30 slides. So pathologists were complaining, why are you sending so many samples? Instead of that, please use this cytolite. They gave us the fluid. So we put the samples on those cytolite. Still, the result was not satisfactory. Still, some proportion of the patient did not give the result. So we changed that into FNB again and try to look at cytolites. We cannot get any impression or idea how good is the sample. But if we smear it on the slide, then we can see some areas. So I want to see those kind of to satisfy myself.
So it also depends upon how we made the slide. Basically, they tell us what I have learned from them, that it should be an oval shape, but it should not be slide. That would also affect the. And if we are, well acquainted with, we can give them a good slide and they will give us a result. It should be an oval shape, but it cannot be spread all over, and it should be thick or too thin.
But the issue is even it is oval shape and satisfactory shape. If there is no material, they cannot get any result.
That's why you get a feeling that yes, it can take that. At that time, you can say yes. We can ourselves go for a road. We can spend some 1 week or something, and it will be good that we make our slides, see the material. I think then we don't need the cytopathologist really.
Tissue is the issue.
Yeah.